Yes. Speak. Thank you, Sarah. We are recording today's call and we'll be posting thank you. We'll be posting the recording as well as today's materials on Confluence. Everyone will receive an email as well when everything is up and running. But thank you all so much for joining us. My name is Gabriela. I'm with EMI Advisors team. It will get started in just a few minutes. As we wait, please feel free to say hello via the chat. I see Dev has said hello. Hello back to you. Sarah and Kyla, thank you so much. We usually get about 50 to 70 participants, so we'll just give another minute or so before we get started. Thank you all. As new members are joining in, just friendly reminder that we have muted all participants to prevent background noise. And we'll get started just in a minute or so. If you are joining us for the first time, don't be shy. Feel free to say hi in the chat. You'll get to see some other team members. And as mentioned, if you can, please add your organization name next to your Zoom name so we have an idea of where you're joining us from. Perfect. So the next, I think, 30 seconds or so, we'll get started to be respectful of everyone's time. That's me. Let me mute that. Great. Hello, Chris. We have two Chris's. Thank you, Chris's, for joining. Okay, we'll get started right at 3:02 to be mindful of everyone's time. Okay, great. I see some more people saying hello. All right, it's 3:02 Eastern time on my end. We'll go ahead and get started. Thank you all for joining us. This is a Social Determinants of Health Data Exchange for Chronic Disease Prevention Initiative. Our work group meeting number 7 is about to start. Today, we'll be doing an end-to-end review of the use cases that we have talked through for various weeks and go over the consensus voting process to finalize that deliverable. So thank you for all the support and engagement. We warmly welcome you to today's call. Due to the large number of attendees, everyone has been muted. We are recording today's call and the recording will be available for everyone's reference. Within 2 business days, you will receive an email once it is up and running. Throughout today's work group session, we really encourage you to participate, share your input, chat with us. We want this to be a bi-directional exchange. Everyone has done so great in the past few weeks and we want to continue that trend. You can, if you chat, please make sure that all your chat messages go to everyone. And we also welcome you the use of reactions within Zoom. There is a raise hand feature and that will be a cue for us to make sure that we unmute you or that we have space for you to share your thoughts, questions, or comments. For today's agenda, we'll start with some welcoming remarks, grounding the team, briefly recapping on the background of the initiative, and then we'll dive into on the summary of feedback received on use case 3 and discussion. From there, we'll go over the consensus voting process. For some of you, this will be the second time that you'll see this information, but we are really here to support the process. And then from there, our colleague Sheetal will take it away with a review of the use case package. And then we'll wrap up with homework and next steps. Some more people trickling in. If you haven't done so, we really encourage you to please officially join the work group as a registered member. You can check your membership status and others from your organization via the link that was just shared via the chat. If you are new or you're having, any issues getting our emails, we really encourage you to please contact your IT department to whitelist our domain. As you can see here, CDC SDOH Workgroup at lists HL7. This is, a compilation of over 200 members that are part of this initiative. So please make sure that you, follow that if they have any issues. Myself, as well as Sarah Behol, who is supporting today's call, and our point of contact at CDC, Kyla Davis, are available to support any questions that may come up related to the work group. We have come a long way. This is a schedule of the first 4 sessions, and today we are on July 13th. As mentioned, we'll be doing an end-to-end review and going over the consensus voting process to finalize the use case package, which is our final work group deliverable. Honing in a little bit more into our objectives for today. We are so thankful for all of the feedback received during our last work group call on use case 3. Also, a number of you share feedback via email. So we have incorporated that and we'll go over the changes. Then we'll go into the consensus voting process.
Yes, please.
Just kindly ask you to be mindful of your background noise. Thank you. For some of you who might be new to the standards development process or consensus voting process, this will be a good opportunity to ground and learn about the next steps for voting. And then we'll wrap up, as mentioned, with a use case package. As a reminder, we do have some specific elements that are out of scope for this initiative, and that includes defining data exchange standards or data elements related to, but not limited to, race, ethnicity, sex, primary language, disability, sexual orientation, gender identity, and other social determinants of health domains. We are creating these use cases, creating the use cases that do not directly support our scope of work as listed in the project charter. So before we started the work group, we share with all of you our work group charter that really highlights the scope of our work and what's out of scope. So this is taken from our work group charter as a reference for everyone. We are not providing incentives for implementation of the use cases, and we're now developing data sharing agreements or policies as it relates to, again, the implementation of use cases. And we're now developing the fast healthcare interoperability resources implementation guides, also known as FHIR IGs, that is now part of the scope of this work. Background. So how did we get here? Really based on the Gravity Project use cases that have been developed and primarily focused on the clinical care perspective, we are building off that great foundational work. Some of you are very familiar, so I won't go too into detail there, but the Gravity Project put forward 3 specific use cases. One that is focused on social determinants of health screening and diagnosis. The second one focusing on documenting and tracking social determinants of health interventions to completion. And then the third one is gathering and aggregating SDOH data for uses beyond the clinical care. For example, quality reporting, but really the use cases that we are showcasing and will showcase today. We are, building off that use case 3, and we're using SDOH data for upstream in support of public health. We do have the Gravity Project team members. A lot of them are on the call, so we'll be happy to share the link there if you're not familiar with the project already. For any visual learner, it's always nice to kind of see what do we mean by social determinants of health data standards. So the Gravity Project defines standards follow into 4 clinical core activities, starting with screening and assessment, followed by diagnosis, goal setting and interventions. And as you can see on this visual, each little circle represents the codes that are used for those specific healthcare activities. And as you can see here under use case 3, we have a red circle indicating that at this point, there's no use case that exists to define the upstream use of social determinants of health data for public health. Very important there. So with this work, we are taking the past learnings and a great foundation done by Gravity Project and really taking it to a future desired state where we are, looking into publishing 3 high priority use cases for public health. And this effort will extend beyond the ones that was created by Gravity. So we're really, really excited to be super close to the finish line here. Today is meeting number 7. On July 27, we'll have our meeting number 8, and that will conclude this ongoing 90-minute sessions. And we'll be presenting this future state to all of you to vote on July 27. So I'm actually going to now hand it over to Kyla, who's going to share a little bit about the framework that's really supporting our work.
Thanks, Gabriella. And I know we've talked about this framework several times, particularly in Workgroup 1 as well as Workgroup number 2, but we just wanted to have that conversation again, really focusing on what are we trying to do from the public health perspective. And when we're thinking about the public health perspective, we're really trying to understand what are the core SDOH data challenges for public health. I know we're focusing on chronic conditions, but we really believe that the framework that we develop can be generalizable to other diseases and conditions as well. We're really thinking through not just using the Gravity framework, but really looking at the HHS SDOH action plan that we have here. And you could always click on the link to learn more about it. But HHS is really challenging agencies like CDC to provide steps in how we could actually help address those core data challenges. And once we really can address those core data challenges, HHS strategic approach is really going to help us drive our progress through coordinated strategies, as well as activities to better integrate health and human services and to help advance our public health initiatives. And really, they're really stressing a 3-pronged approach. And we feel like what we're doing, particularly for this initiative and the conversations that we're having, really aligns with the better data, as you can see here, that we have pointed out here. And so that better data really dives into making sure that HHS is collecting high quality data, but not just collecting high quality data, but then also that we're able to build an interconnected data infrastructure that can collect, link, and integrate this data and share it across the health and public health ecosystem. So I just want to continue thanking everyone for participating in this initiative, for helping us think through our challenges, but then also helping us think through how we could actually go about addressing these challenges as well. So thank you, everyone.
Appreciate Kyla and CDC team's leadership. And yes, absolutely, Juliet, use it to respond, to address patients' needs. Absolutely, making sure that that is elevated. Thank you for that comment. And we'll pause here for a brief, brief pause and see if we have any questions from the audience. All right, hearing none, I will continue to move us right along and transition to Amy, who'll do a recap on the feedback received.
Thank you, and good afternoon, everyone. Next slide, please. So as we've done, in case there are any new members or someone hasn't been to a meeting in a little bit, we just generally like to refresh everyone's memory on the personas and the story of the 3 use cases. So I'm just going to very quickly do that. But just to remind everyone, we have Kevin, who's a care coordinator at a federally qualified health center, and Jessica from a community-based organization. We have Claudia at the county health department, and Victor at the state health department, and Michaela at CDC. And the 3 use case stories, the use case 1 really focuses on community health needs assessment, leveraging aggregated SDOH data. And again, just to remind you, in this story, we have Kevin and Jessica who are at a public health advisory meeting. They comment how they're seeing an increased number of patients with food insecurity. Claudia at the county health department is trying to do a community needs assessment and decides it's important based on their comments to assess the burden of food insecurity among people with or at risk for diabetes in the county. She wants to leverage SDOH screening data from clinical and community providers, learns that most of the clinical and community providers send data into the HIE, which has some of this. And so she works to get the HIE data. She also wants to look at data on the types of interventions and social services and programs, really to help look at where there may be gaps and to continue to focus on the community health needs assessment. So that was use case 1. And again, in the use case package that Sheetha will walk through, there will be much more detail on these stories. All of the feedback and additions that you've provided to us are in there. I'm getting very high level comments at this point on the stories. The use case 2 really focuses on the assessment of state, tribal, local, and territorial health department diabetes programs. And in this use case, Victor is assessing state and CDC funded diabetes programs in his state, which he's going to then need to prepare for his continued application for continued funding from the Division of Diabetes Translation. And again, he also wants to address food insecurity levels in areas of the state where there's a high, there's a burden of, where the burden of diabetes is highest. He learns that the regional HIE has data, but that's not all the providers in the state. So he works with clinical and community providers. He also works with Medicaid that may have some data on this, to collect all this data. And he overlays the data with where the state's Division of Diabetes Translation funded program initiatives are to identify areas in the state, again, that, where he needs to prioritize programs, and he disseminates the data back to the community to help inform where there may need to be additional programs, help think about allocation of resources and program planning. And then in the third use case, which is what we went over last time, next slide, please. All right, sorry, these are the personas for all of the use cases. Next slide. So on use case 3, here we have Michaela, who's a project officer in the Division of Diabetes Translation. She's been speaking with Victor, learns how he leveraged community, clinical, and Medicaid data, and sort of to better understand food insecurity for those individuals with diabetes or at risk for diabetes. And Michaela really wants to make sure that all of the awardees leverage data to better assess and monitor their program in accordance with the cooperative agreement requirements. And the Division of Diabetes Translation really encourages their awardees to implement food insecurity strategies to track and report the number of individuals with diabetes by demographic factors such as race and ethnicity. And then also Michaela and her team provide technical assistance and support to the awardees to help them better assess SDOH activities that will support diabetes prevention and management strategies. And the division as a whole then uses this data to assess progress towards their targets. And the data is aggregated really to look at population health trends and identify innovative practices. And again, importantly, Michaela and her team will disseminate the summary data and any analytic results through dashboards or benchmarking or reports to all of the program awardees and to other national and public health partners and federal leadership to help inform better data-driven decision-making. So those are the high-level use case stories. And again, use case 3 we went over last time, and I've just gone over the major players there, which is the awardees and both national associations and the state, tribal, local, territory health departments, and then CDC and the project officer. So next slide. And here's the transaction diagram, again, showing the awardees sending data to CDC, Division of Diabetes Translation. So we talked last time, next slide, please. Now what I really want to do is focus on the feedback we received and what our response is. So we had a lively discussion last time, which was really helpful with a lot of feedback. We also got some written comments afterwards. And so as we've been doing in each meeting, we really want to make sure we share with you how we've taken your feedback and how we're planning to address it. So we did get some comments about that there was a precondition in use case 2 and 3, and that we really focused on sort of mapping and GIS tools, and that the analytic tools should really be much broader. So we've reworded the precondition in use case 3 and clarified that the information recipient, which would be the State Health Department or CDC, has the necessary analytic tools or capabilities, rather, not just tools, but the capabilities to better understand food insecurity in areas, with high rates of individuals with diabetes or at risk for diabetes. And we've sort of said it's not just GIS and mapping, but other examples would be for other methods of analysis. So that's how we've addressed that comment. We had another comment, and this was raised last time in the discussion, that, asking sort of, well, where do the private vendors and platforms that are collecting SDOH data and perhaps doing e-referrals fit into these use cases? So we wanted to clarify, and we have done this in the use case package, that when we use the term trusted intermediary, it really refers to any data aggregator. In these use cases, we've specified the trusted intermediary as an example is an HIE, but it's really can be much broader. So we've sort of clarified that, and that's how those other private entities or platform vendors would fit into the use case. We also had a comment around, we've had multiple comments around the fact that it's really important to have bidirectional flow into the use cases and the transaction diagram. So how, when this data goes to public health, what happens? How does it get shared back? So as you heard me say and elaborate on a little bit this time in the stories, we've enhanced the story to say that public health, whether it's the county or the state or at the national level, CDC, is sharing back the results of the data analysis to their stakeholders. And we are going to include, and you'll see a diagram, not a transaction diagram, but another diagram in the use case package, and Sheetha will go through that again, that illustrates sort of the summary data and analytic results being disseminated and shared back. So because the data is aggregated and more in a report form, or maybe it's a dashboard or through benchmarks, it's a little different than the actual transaction data getting sent to the public health entities. So we're displaying that, but we want to make sure we've captured the fact that this is being used for public health purposes and it is being shared back with the stakeholders. Next slide. So we also had some comments that it would be important to include an assumption that the information sources and recipients have the appropriate methodologies to identify and remedy duplicate records. So we have added a precondition, you can read it here, that's basically saying that information sources and recipients will share data in a secure manner, which we've sort of alluded to, clarified and called out each time. And doing that with appropriate methodologies that also support identity management, identity resolution, including the deduplication and record linkages. And I'm going to skip to the last item on this slide, because the precondition actually applies to both comments, but we also had a comment around considering we had that PPRL would be identified as an alternative flow, and the comment came back, well, it would be important to know who would be applying this if this was going to be a way in which de-identified records would be linked and shared with CDC. And so again, we don't want to specify a specific methodology. We want to be generic for broad applicability. So we believe that the precondition applies to both those items, the first and the third, on the feedback we received on this slide. And then we also had comments around again, the assumption that we needed to address the assumption that we had that all program awardees capture social determinants of health, diagnosis, goals, and intervention data using the nationally recognized terminology under the Gravity Project, but that program awardees are really dependent on receiving the data from their health and social service providers. So how can we make this assumption? We recognize that the assumption is not the current state. We've commented on that several times, but we really believe it's important that through this initiative, by focusing on capturing SDOH data And this type of information on diagnosis goals and interventions using these nationally recognized terminologies under the Gravity Project will really help drive adoption and get us to a desired state. So again, we just wanted to call that out. And next slide. So we also had some comments that recommended that the funding that's coming from the Division of Diabetes Translation include or be used for public access to virtual and remote services. And we will include this as a recommendation in the final report to CDC. We had a comment that the data collection and performance measures, SDOH data collection and performance measures should be included with electronic case reporting and contact tracing, and we'll include this as a recommendation. We also had a comment that we should update an assumption to include that data is shared using a zero trusted security model. And as I said before, we really recognize the importance of assuring very strong security measures are in place when sharing data, but we have chosen to avoid naming specific approaches. And there is an assumption saying that all the data that will be shared will be in compliance with federal, state, privacy, security, and consent laws. So we felt that was addressing that. And then the last bit of feedback we received, next slide, please, was, and we had this conversation at the last meeting, and there was a lot of support from the group to say we should expand actors to non-CDC DDT awardees in the transaction diagram and not limit data being sent to CDC from just program awardees. So we went back and we had a lot of conversation with CDC, and we have Gia Rutledge on the call, who I'll ask to make a comment in a minute. And we spoke with her and others on the CDC team, and we learned that the DDT really needs OMB clearance to be able to receive data voluntarily from non-awardees. The team, we also then talked with them and Gia about adding the lifestyle change programs and diabetes self-management and education programs that are certified by CDC. Because they're certified, there is some reporting data to the Division of Diabetes Translation. But the data that's collected may be different. And in the end, we are recommending, we thought the best way to approach this would be to add recommendations to the final report. Again, to have CDC consider supportive or enabling policies or regulatory levers to think about how to enhance their ability to collect data from non-awardees. And with that, I'm just going to see if Gia wants to add anything to what I just said there.
Yeah. And just to clarify, so typically in DDT, we collect data around strategies that our recipients are implementing for the national DPP, or as we call the CDC Lifestyle Change Program, and diabetes self-management and education strategies. Those grant recipients are required to report us that data as a part of their grant requirements. However, we are also the accrediting body for the National DPP Lifestyle Change Program to make it a CDC recognized program. We are not that entity for DSMES, which is our Diabetes Self-Management Education Program. That is American Diabetes Association and ADCES. So to try to weave this into the story makes the story more complicated. Because we also collect different types of data under those 3 different circumstances. So as it pertains to this use case and this story specifically, where we're talking about a project officer named Michaela and her director, Victor, this story aligns more with the requirements that we have for our recipients reporting. That just gives some more context. If not, the story didn't flow as accurate in how we collect data and what data we have authority to collect or require.
Great, thank you so much, Gia. Really appreciate the additional context and background to that. So are there any additional comments or questions on how we've responded to the feedback we've received, or thoughts? All right, hearing none, then I will turn this over to Sheetal to go through the use case package.
Great, and I think we have one or two more, and then Gabby will actually talk.
Great. Thank you all. Yeah, I'll happy to take it over from here. Thank you, Amy. So we just wanted to echo that we are still open and collecting additional personas from work group members. So if you are interested in sending a candidate, Amy went over the 5 key personas for the purposes of our story. If we feel very strongly that we should add another type, I know we have 4 submissions received to date, including a patient and some other persona types. We definitely encourage you to do that. And as part of our homework and next steps, I'll go over in detail on, instructions there. But I know that we already kind of paused for questions, so we'll move us right along. And as part of, coming to our finish line here, we wanted to ground everyone on the consensus voting process that the use case package will go through. So right before going into it, we'll give you the heads up on what to expect from a membership level. So some of you who have joined us from the beginning will recall that we have 2 levels of participation through this work group. What we call committed members, and those are who attend regular meetings. Again, we have met bi-weekly since April, and actively contribute to the development of our work group deliverables. So these committed members are able to vote on deliverables, and that is approving and ensuring that there is consensus on the documents and everything that we have reviewed thus far. The other type of participants is what we call other interested parties. And these are participants who follow the progress, join meetings, may not be able to join every meeting, but they still want to stay at bay and inform about the initiative. They can submit comments, feedback live, but the differentiation here is that they are not able to cast a vote during the deliverable consensus voting period. And we're using the consensus voting period to finalize deliverables, which are going to go into the next couple slides. So please, if there are questions, don't hesitate to chime in via the chat or raise your hand. So the collaborative consensus process is a core value of most standard organizations and really supports the governance process. So as part of following the due process, we do open consensus voting for at least 1 week where participants, committee members are able to vote on a specific deliverables. For the purposes of our work group, we're using SurveyMonkey survey to be able to collect those votes from our audience. So there are a few categories, but highlighting here that a vote that is no will be considered a formal objection. And so any vote that are no with comment and any yes with comments will be addressed and resolved in a timely manner to continue, with the consensus process. Only committee members are able to vote on deliverables. To learn more about the collaborative process, you'll have a link here when you get the slide deck, but it's really kind of highlighting why it's important. So it really is to allow equity and fairness. So being able to support open participation, a balance of interests, and equal opportunity for all participants without any dominant positions. So we're able to not only embed your feedback and comments, but really being able to showcase with voting that most people agree that this is the best way forward. So it really is an opportunity to address all views and aim to resolve any objections or disagreements in a timely manner. For this specific work group, and we're following the framework of Gravity project. So some of you that are in that project, this will be very familiar to you. So during the consensus voting period, all committee members will be asked to vote. And we will need at least 60% of committee members voting, approval voting to reach consensus. As of yesterday, we have 229 members. 100 of those are committed members, which means that we will need 60 votes in order to approve the use case package as our final deliverable. So in the back end, the reason why we use SurveyMonkey is because it allows us easily to get those numbers and kind of review the votes in a timely manner. So voting instructions, again, this will be all laid out on the SurveyMonkey for everyone's review when you get it. So all committee members will be given at least 1 week to submit their vote. You will see 4 categories. The first one is yes, a plain yes, and a yes vote does not necessarily mean that the deliverable, in this case, the public health use package, is the ideal one from the perspective of the respective member, but it's better to move forward than to block the deliverable. So I want to be very cautious here that you are in agreement in general with the sentiment, the intent, and the process that kind of went into it. Yes with comment, it provides an avenue, an opportunity for that specific member to share, where might be any revisions or suggest any revisions. So it's really an opportunity to provide additional feedback if you have it on a specific sections of the package. A formal objection, as mentioned, is considered a no vote. If you do a formal objection, you must include a comment indicating the path to address the reason why you're objecting. So a formal objection without any comments will be considered an abstain vote. And an abstain vote means that the member declines to vote. So I'll say, I think this is kind of pretty straightforward, but please, we want to ensure that all of our participants are well aware of our instructions. So now kind of going into the timeline. So today, as you can see here, we have the start. July 13 is where we share the proposed use case package. So we're introducing it and we are collecting live feedback from the audience. You will have until July 18 to provide comments. So, at specific areas, edits that you might like to see. And then from there, we're going to consolidate all of that input from today's call, any comments received via email by the 18, and we'll present to you the final version of the use case package for consensus vote on July 27. So this is where vote will start, will kick off. We'll actually have committee members will have the opportunity to vote live on July 27. So it's really important that if you have been with us, thus far, and you're continuing, you have any conflicts, please let us know, but it will be ideal if you're able to join us on the 27th so you can cast your vote live. Then from there, we will, closely monitor the votes. The voting period will end on Wednesday, August 3rd, aiming to share the analytics of votes by August 5th, which is a Friday. So we'll have, that following week to give you back the report there. And then from there, we will publish the public health use case package. Again, being able to respond to all of the comments received through voting. Our target date is August 8th. It will be available via our Confluence site as well as Gravity Project media channels. And I'll pause there to see if there are any questions or concerns about our process. I do see a comment in the chat. Thank you, Jim, for sharing. Yeah, that'll be great to share with the remaining team members. Perfect. So there is an ONC is having a workshop on August 16 on e-consent for anyone that is interested. SDOH and social services data will be part of the topics of discussion. Thank you, Jim, for sharing. Let's see, great. Again, you will have access to today's slide deck. So if you want to reflect back on any of the instructions, you have any questions, we are here to support you. And now, without further ado, we'll pass it over to Sheetal.
Awesome. Thanks, Gabby. And thank you, everyone. Good afternoon. And just so excited to go through the use case package with you. If we go to the next slide. Yeah, for folks that might be joining us for the first time or would benefit from a bit of a refresher, as we go through the package, we want folks to just have these questions in the back of their minds. Does the story and the use cases, are they meeting the needs of public health professionals? Are we providing a compelling reason to leverage this aggregated data related to social determinants of health? Will this have broad applicability across the public health ecosystem and help us drive towards that desired state? So please be thinking about this, in the back of your minds. And again, at any point, if you have a question, please do not hesitate to raise your hand or a virtual hand, or put the questions in the chat. And my colleagues will be monitoring that. And so we welcome any feedback. Please always feel free to interrupt us as we go through this. Oh, and Dr. Lucas has a question. So will the additional submitted personas be included in the final package or considered for a future date? And the answer to that question is they will be included in the final package, and they'll be part of the section that I review shortly in the package. So stay tuned for that. So feel free to just drop in questions as we go, and we'll do our best to respond to them. If we go to the next slide, please. Yeah, so just to recap and a preview about what you're about to see. So the use case package is the deliverable. That's the output of this work group. And hopefully you'll see that, we're just so grateful for the collaboration and input of all the members, into this, draft version of the package. And so in the previous work group meetings, if you've had a chance to join us, we've looked at use cases 1, 2, 3, and gone over in each meeting the associated actors, transactions, alternate flows, and preconditions, postconditions. And now what we're attempting to do is package this all together in a standalone deliverable. If we go to the next slide. And then again, just as a quick refresher, the key definitions that we'll want to just briefly walk through with folks is, the use cases, right, describing the interactions between the systems and its users. We'll have the actors, which, as Amy just showed in the recap of use case 3, includes our human system and technical actors. The assumptions are, those items that we want to be true or in place that could be related to the execution of that specific transaction. If we go to the next slide. We also specify the preconditions, which refer to the initial state of the system before that action or transactions occur, the transaction, the data exchange between the two systems. The message content, we like to specify the categories of data that would be included in the content, and then as well as the post conditions, which refer to any state of the system after the result of that transaction. And then in the alternate flows, we alluded to this as well, but we know that this is a really evolving landscape, with new actors, new things are emerging every day. So we wanted to ensure that the alternate flows also describe the breadth and really the diversity of the ecosystem, that we know that these use cases and this data could flow through multiple different types of actors and information sources and recipients. If we go to the next slide. So we're working on this use case package, which we're about to preview with you, which is a little bit of a lengthy deliverable. So I'll just warn you about that. So I apologize in advance. It's somewhat long, but we want to have a really final professional draft for you all to view. So we are going to have this cover on here, and with that I'm going to now switch gears and actually walk through the use case package with folks. So thanks, Gabby. And okay, here we go. Okay. Great. So hopefully folks can see my screen here, and I'll just scroll this up.
Yes, we can.
Okay, perfect. So So just walking in, so again, this is our use case package, which tries to consolidate all of the information that we've gone over the last, 6-ish meetings to date. And so I just want to first, I actually highlight this for folks. So today, we are walking through the use case package for the first time, and we really encourage folks' feedback. Feel free to, again, interrupt us or raise your hand or put your questions in the chat. We'll love to collect this feedback live, but I know this is a Word document. If it's easier for some people to take a look at this document after the call and provide your comments, directly to the document, welcome that as well. And so today is the first opportunity, as Gabby went through in the consensus voting process, that we'll review this. And then further after that, just to remind folks, we'll launch your feedback by that July 18th timeframe. And then we'll come back to this meeting July 27th and summarize what that feedback was by our work group members, and then be able to publish this document for consensus voting. So that's that table here. And then over here, again, this is just the outline of the package, and just moving us ahead. So we start again, and we believe we have such a diverse representation of folks from across all sectors of the ecosystem. And so with this, we know that the audience for this actual deliverable could be varied. So we start out with the preface and the introduction, trying to highlight the CDC, National Center for Chronic Disease Prevention and Health Promotion's priority areas, as a center, and what its key objectives are. And then we go into what are the specific priorities as it relates to SDOH. So all of this we've tried to lay out in front, so whoever the audience or the folks that are reading this have that grounding and information about the strategic priorities of the center and its mission. And then we flow into the Gravity Project. And so how the center, hope to leverage the efforts of the Gravity Project as a multi-stakeholder collaborative to help develop standardized data for supporting social determinants of health. And so we put a little bit of information and background on the Gravity Project in case folks might not be familiar with that. And then from there, we go into the initiative overview, and we talk about just the grounding for and importance for this initiative, and trying to build off of the great work that's already been laid out by the Gravity Project and all its members. And then this might look a little bit familiar to folks. So earlier on in the work group, we developed collaboratively the public health business case. And so we wanted to pull out that language here just to ground the audience of this deliverable to why is this important, and what's the business needs statement. So we pulled that language and we wanted to bring that in here so folks understand what's the problem that we're trying to solve through this work. And then for any folks that might not have had a chance to see it, we have a reference to the link on the Confluence site here. And then from there, we go into the use case scope and approach. And so we give background again on what we hope to accomplish through this work group and initiative, the objectives of using this consensus-based approach, and developing what we hope are high priority use cases to support public health. And we go into that. We talk again, as Gabby also mentioned earlier on in the call, we also like to just define what was out of scope for this initiative. So folks are aligned and on the same page of what we know that we purposefully did not cover through the scope of our work together. And then in the next section, we highlighted all of the partners that have been engaged. And there's a really diverse, wonderful group of now, I believe, about 200 committed members, which is pretty amazing to have folks across all these different sectors of the ecosystem participate, provide their input and feedback and reflections to help us build these 3 priority use cases. And then we go into the use case approach. And so, kind of the activities of this work group. So first, developing that really clear public health business case, articulating what the business need and the value proposition was for investing and engaging in this work. Then working on developing the story that represented the personas and the specific uses for leveraging this SDOH data to support public health. And then from there, developing those 3 high priority use cases. And then as we go into that, we talk about the personas that were collaboratively developed through this process with the work group, just some of the areas that we focus on specifically. I know some folks in, personas development can take, weeks or months. We unfortunately didn't have that opportunity to do that here, but we did want to, just point to what we did focus on. And then as well as there were the ones that we prioritized focusing on in the stories, but then we also wanted to ensure that the additional personas that the work group members submitted were also included in here. And that's in Appendix C, which I'll bring folks' attention to when we get to that section. And then here, again, just grounding for the audience, the story, the use cases, a lot of this is taken from the slides, but again, just grounding whoever the reader or the audience is, if they were picking this up for the first time, can understand what we were trying to do in the context of our work. And then here is where we actually go into the detailed story that Amy discussed earlier on the call, but that's just in a bulleted form. So if folks are new to our work, here's where we have this, complex public health story. And then each part, we've broken it into kind of 3 parts that align to the use cases. So not to, read every single word on the page, but we, start again with, Claudia, who's at the County Department of Health and working with her stakeholders to understand the community concerns and emerging public health issues. She interacts with Kevin and Claudia, who work at a FQHC and a community-based organization respectively. And they're working through the process of their community health needs assessment. And so that's how that part of the story unfolds. And then we transition over to Victor, who is working at the State Department of Health and his work in trying to assess the state and CDC funded diabetes programs in his state, and the work that he's hoping to understand and analyze a little bit better, and hoping to leverage the aggregated SDOH data for that regard. And then lastly, we have Michaela, who is our project officer with CDC's Division of Diabetes Translation, which you'll see us use the acronym DDT, and how at the national level, trying to leverage this aggregated data to support individual, community, and population level efforts related to the priority social determinants of health. So we have that all bulleted out. So certainly welcome folks' feedback, up once, on the call, or also as you get a chance to maybe sit with this document and review it a little bit further. And I just wanted to mention something. I apologize, I didn't mention it before, but we've based this deliverable off of the Gravity Project's use case deliverable packages. So folks that are familiar with the use case package deliverables with the Gravity Project, we've kept a lot of the similar structures. So for some folks, it may look really familiar. And then for others, just wanted you to know that, we didn't want to reinvent the wheel and really try to leverage the framework that the Gravity Project has used in the past. And so then going a little bit further, we have the story assumptions. So, as we were going through all of the use cases, we wanted to pull out the assumptions that we felt were, or we believe to be applicable to all parts of the story. And so some of these are grounded in, ensuring appropriate compliance with federal and state privacy, security, and consent laws, ensuring there's the appropriate governance and data use agreements, ensuring that the SDOH related data is, being coded to the nationally recognized standards and code sets, and that we are also wanting to state upfront very clearly that we know that this data is not representative or complete data on all persons in a specified area on a regular basis. I think that was really important feedback we heard throughout these work group meetings. So wanted to ensure the ones that we felt were applicable throughout all parts of the story were clear to the reader up front. And then we go into the actors. And so the only thing to mention here is that I think we've mentioned this in previous work group meetings, but just to call out is that we did want to leverage existing definitions where, it made sense and it was applicable to our story. So we just called out the definitions that we leveraged from the MedMorph initiative and placing that link in here and how we define some of the technical systems. So just wanted to bring folks' attention to that as well. And then the next section is related to use cases. And so just going back, so Amy mentioned this, I think, in the table of feedback, but essentially, we now dive into the 3 high priority use cases. And another consistent theme we heard from work group members was that, we really need to show that public health is aggregating this data and sharing the results or the analysis back with all its partners and stakeholders. And so we are working on a visual diagram that hopefully brings that point home. And so I just wanted you to know that it's here. I think it's still in draft form. We're hopefully getting another turn of it that we'll include in the deliverable that gets posted very shortly, but just wanted to let you know to also feel free to give us feedback on that as well, because we are really hoping to show that at these different levels of public health jurisdictions that this data and information is being aggregated and then also shared back out with the community and all the interested stakeholders that would benefit from the results of that analysis and work. And so we've bucketed it into categories that, we've heard from others in terms of, providing dashboards or visualization tools or other methods of analyses, or looking at emerging trends and the evaluation of the impact of programs. And so, we hope that this gets to the feedback that we received around the importance of public health jurisdictions sharing this information back with members of the community.
Hi, Gito. I do see a question on the chat.
Yeah, great. Thank you for interrupting. Okay, so under assumptions, Dr. Lucas is asking, will the gravity technical standards workflow be used as the data exchange standard format? And so, Dr. Lucas, would you mind just elaborating on the question a little bit more?
Sure. Part of gravity, there's 2 tracks, the technical and of course the data standard track. And when I've been working on that project, and so on the technical track, they have standards for and a guide for HL7 and FHIR sharing of data. And so when data is shared with the CDC, will there be a document to just determine how that data is going to be shared and in what format?
Yeah, thank you. I'll take a stab at answering this, and then Evelyn, Amy, or others feel free to weigh in. So I think in the assumptions, we do have in the story assumptions, I know we want to ensure that they're using nationally recognized terminologies. And I think, Dr. Lucas, your question is, for those who are familiar with the gravity track, there's the terminology work, but then there's also the work of kind of building out the FHIR implementation guides that more closely define, right, how this the flows and the transactions can work. And so in Appendix D, Dr. Lucas, and I'll get there in a moment, we do want to show the different related standards that could be used to support the use cases. And in the assumptions of the different, if I just drop us down here, for example, in use case 1, which focuses on the FQHCs and CBOs sending data to an HIE as part of the first transaction, and then the second transaction as the trusted intermediary sending to the County Department of Health. We do add assumptions around utilizing, I believe, like all those nationally recognized coding terminologies, but I'm not sure we specify necessarily the technical framework. And Evelyn, yeah, feel free to go ahead.
Sure, yes. So the use cases, this is to acknowledge and list out all the transactions that are needed and what actors are involved, right? And what's part of the message content. Well, what would happen is this use case would then inform another Fire IG, right? Where you can, but it can also inform any updates. So again, we say we're agnostic to the content and transport standards because it, most likely will be fire, but we know that there's a lot of data moving right now using still CCDA and direct. Other existing standards can be used, right? So for us is really acknowledging what are those transactions needed, knowing that there may be different modes of exchanging the data based on what existing data infrastructure will be used to implement the use cases.
Yeah, I guess my only comment on that is that typically the receiving organization, which will be the CDC, knows what data format standards they accept.
Perfect.
So somehow we just need to make sure that when we're sending in a format that they can accept.
Yes.
Yeah. Great. Thanks, Dr. Lucas.
So Shita, this is normally what happens is that the technical spec with the two talking entity, the business agreements, are the ones that document how their transactions, which transactions they're using between each other. So that's usually included in the technical spec that will be between CDC and whoever they're communicating with.
Yeah.
Where that documentation is.
Great. Yeah, thanks, Emma, for that feedback. And thanks, Dr. Lucas, for that suggestion. I think we can probably try to add some just more clarifying wording to that point. Great. Awesome. Thank you. And thanks, Gabby. Feel free to, if more come in, feel free to interrupt me. But I'll just quickly, so hopefully the tables here are hopefully, if you've been on these previous work group meetings, this is how we've basically tried to go over the use case package. So I'm not going to spend too much time on these various tables, but feel free if folks get a moment to look at it, because we've gone through these different use case tables and incorporated the suggested feedback with each use case 1, 2, and 3, as Amy also covered in our previous meeting, or sorry, in the previous part of this earlier part of this meeting. So this has all those tables aggregated in one place all together. Use cases 1, 2, and 3. And then just to almost quickly wrap us up, there's just some information in the appendices that I wanted to highlight for folks. So, and then we also mentioned some issues, risks, and obstacles as the last main section of the deliverable. But Appendix A, for folks who might be, here with us for the first time, or again, want to know a little bit more about the personas that we've developed, here are the main human personas or human actors, and a little bit of more of that information and detail about them to really help us understand their goals and their needs. And so Appendix A has more of that detailed information we covered earlier on about Jessica, Kevin, Claudia, Victor, and then Michaela. And then we also wanted to point folks' attention to Appendix B. So throughout this process, we wanted to basically make sure and ensure that we were incorporating the workgroup members' feedback. So in this table that you'll see is the consolidated feedback that the members have provided related to the personas, the story, as well as each of the use cases. So here is just kind of that that summary information. So if you're, again, here, maybe for the first time, or Chris, I know you mentioned if you're playing catch up, just wanted to let you know that there's this table here that you can go through and learn about what other workgroup participants, what their feedback was, and then how we try to incorporate and address that. So It's a bit of a long table, but hopefully that's good for folks' awareness. And then lastly, this is the additional persona candidates we received. So we were super excited that workgroup members provided this input because we know we didn't have the opportunity to cover all the potential stakeholders or personas that would want to leverage this data for their purposes to support public health. And so we wanted to, have the workgroup members submit these additional personas, and then here is where they are included. So we have a couple of new staff members from FQHCs in here. We have a patient, like Gabby mentioned earlier, and then we also have a business owner from a durable medical equipment company. And so if there's any others, again, please feel free to suggest updates or additions. This is the time where we would love to get all of these, diverse, stakeholders or personas represented in the package. Just think that's so valuable and really help carry this work forward. And then, sorry, last but not least, Appendix D. And so this is some of the available document and FHIR resource standards to support the message content under the use case package. And so here, just Dr. Lucas, and then as Evelyn mentioned earlier, we did want to provide some of the options that folks could use as it relates to the transport and data exchange requirements. So we just have that actually as a reference in this document as well. And so I will pause here, and then some applicable population search parameters as well. So I will pause here and see if there's any questions or thoughts or reflections. And again, going back to the questions we posed earlier, want to make sure this is a helpful output of the work group to really support public health purposes and leveraging, this aggregated SDOH data. And so I'll pause here and see if there's any thoughts or reflections.
Thank you, Sheetal. That was such a great overview. A lot of great work, and I think from all of the entire team. I don't see any questions in the chat, but really want to encourage people, if you don't mind speaking up. Like, does this resonate? How we heard and validated your feedback? We really love to get a little bit of that input. Thank you. I do see a comment. This is great. Thank you, Dorella. Appreciate the support.
Great. Yes, and please feel free if, of course, I know this is a very lengthy document, so welcome feedback if you get a moment to look at this, and yeah, certainly look forward to hearing folks' thoughts and feedback. So Gabby, I'll pass it back to you. Thank you.
Sorry, I was just muted there. So I should be able, are you able to see my screen? All right, wonderful. And again, kind of to continue a little bit of the discussion, and as you get a chance, we will reflect in that comment provided by Dr. Lucas and making that assumption a little more clear. We'll be posting a Word document so you're able to dive in, embed your comments. We know that we have an array of expertise in this virtual forum and room. So if there's a specific area that you would like to focus on, whether that is, within the use case or overall the intent, any future risks of this work, we'd really commend you. We know 45 pages is a lot to review. So if there's, based on your expertise, you would like to zoom in on a specific sections based on the outline, we encourage that, and keeping these questions in mind, as Sheetal echo, does it provide that compelling reason to leverage SDOH data for public health purposes? Really appreciate the positive comments. Yep, we'll definitely give you some time to read and review. If there are any edits, we'll be very happy to address them. So we'll now jump into next steps a little bit, and definitely as more questions come in, let us know. So if you were unable to provide feedback during today's call, you have a little, you're taking it all in. We will, as mentioned, right after this call, within 2 business days, we'll post the package. I would say hopefully by tomorrow, it should be ready to go. And then you can download it as a Word document and send your input to me via email. We're consolidating that together. As mentioned, if you are able to submit an additional persona, so we have a few candidates already. Again, we'll love to have more. I know community health worker was something that was mentioned in early meetings. We don't have an additional persona for that. That might be an opportunity to submit. We heard some, again, maybe payers, but we want to hear from you. So we'll download, if you can download the worksheet, it gives you the specific areas that we're looking for and an example featuring Victor, who is part of our story. So you're able to provide input that way. And that's a nice template to follow. Again, we'll love to get all of the feedback by July 18th. So we're able to assemble it and package it for the 27th. Sometimes there are areas that we need to clarify on the input received. We want to have enough time to ask you some follow-up or ask you to elaborate as needed. So that is why we're aiming for July 18 as that target date of getting input from workgroup members, which is a Monday, if I'm not mistaken. Pause there for a few seconds and see.
I have a question about the submitted personas. Are we planning to review those? I was really interested in the patient persona that was submitted and what exactly data are we expecting patients to be able to share. I'm not sure if they're referring to remote patient monitoring integrated devices or patient actually submitted data via portal.
We can go, so we don't go into those details in the persona. We can actually go through the template if that helps, just so you're able to see exactly what we're looking for. Does that work?
Yeah, that's fine.
So let me, thank you.
Yeah, sure. And yeah, Gabby, if you want to just scroll down to that one, perfect. Yeah, so Dr. Lucas, we asked folks to just kind of put in mostly the psychosocial information around the persona. So like some of the demographic information, what are some of their preferences or their challenges and goals, and not necessarily like actually baking it into a transaction, if that makes sense. So we wanted to basically compile all the different potential types of users without actually going into like necessarily what would be the transaction. So I think you mentioned like remote patient monitoring or integrating devices from that perspective. We didn't go into that level in the template where we were asking for that information. Does that make sense?
It does make sense. I just not really clear in my mind since we're trying to collect social determinants of health data, how this is going to be used by a patient and how the patient is going to contribute.
Yeah, and I'd open it up to the work group or other members of the team. I mean, and folks even on the Gravity Project or Evelyn, if there's, I don't know if there's been use cases that have come to the forefront on that could help answer Dr. Lucas's question.
No, that's interesting. No, these have not come up in our discussions because our current use cases, again, as stated, they start within the clinical encounter, and patient data is, them informing, completing their social risk survey, and maybe more around patient reported outcomes. But we've not had a way, to circle back, to think this through from a public health perspective.
Thank you. And I'm displaying the example that we received from the patient, just so you're kind of aware of what we received. And it does specify like on preferences, a little bit about what might be the chronic condition, and then, challenges and sort of kind of the background.
Yeah, and when you look at this, all of the other personas, they actually are in a role that they can actually impact, whether it's collecting data or sharing data. But I'm not sure how the patient, certainly the patient can share data with one of those users. And if that's how this role is, that's fine. I was just wondering from a patient perspective, is their role just sharing data with one of the other personas to be able to contain social determinants of health information. Because if we're not looking at any patient contributed data, then that would be the other way to do that.
Yes, absolutely. I know the Gravity Project use case 1 is focused on that patient encounter with the provider.
Right. Transactions are there. Yeah. So I think what you're asking, Dr. Yeah, because these are submitted differently, they're not part of the patient story right now. But then we would, if they are incorporated, there would be a new story that would need to be created to say how is the patient or individual contributing their data or using the information. And so for us, because of our scope, our limited time with this, we have not done a deep dive on the patient persona.
I would add that when I read this persona, it indirectly fed into the story where, you know, we had comments about how sometimes screening assessments, SDOH screening assessments don't have complete data. And whoever submitted this really is calling out that this individual doesn't want to share data. So as I read this, to me, it was, if it's to be used in a further use case, it's sort of, I mean, the use cases are about sharing data, and this is someone who's reluctant to do that. So it's maybe more on the policy side or the education side in thinking of a story to assure or help this individual understand why it's important to share the data. That's just sort of how I personally took it, just to sort of thinking it through a little bit.
Do we have the person who submitted it on the call today?
I'm not sure. I can confirm. Give me a minute. But yeah, if this sounds something like your rep, please let us know. I can go back and check. Yeah, I know they're all came in a spreadsheet, and we're trying not to identify on this. It's more general.
But yeah, just to add, I think too, is when we ask for personas, additional personas, it gives an opportunity for those that want to create a new story around this and think through what are the transactions. So how could we have this role be incorporated in the story, and what would those transactions need to be to make them comfortable? Because I think we don't want to get into policy or, workflow here, but there are things in particular, if their challenge is around providing extra information or not trusting the system, we want to make sure that the story provides that opportunity to create more trust with the individual outside of just even consent for sharing. One thing is to consent, but the other thing is to trust that their data is useful and isn't going to inform the services they receive, for example.
This is Emma, and a lot of my work I do is on the clinical side, but and also I also focus on what the technology is capable of doing. I always will say, if public health has a use case where a person can report on something that's happening in their community, the technology supports the ability to share observations about a group of people or something like that. So maybe a person can notice that within a small cohort of themselves, that they're aware of, and they want to report that. The technology does provide the ability to share something about a group. You know what I mean? So if they're noticing, for example, like there's a COVID, cluster in this particular area, or there's a cluster of monkeypox or something like that, and it's something that a person may want to report, or a group may want to report, you can also do that within the fire spec, looking at it from the fire spec perspective. But I don't know if that's a use case that public health would use. Because in clinical care, you can do self-reporting, patients can always say, this is wrong with me, or I noticed this about myself. And so patients can, share observations with their providers. And that's how we do it from the one person perspective on the clinical side.
Yeah, and I think there's a note in the chat from Jim that some of that is being covered in Helios.
Thank you. Thank you for highlighting. Yes, perfect. So I just want to go back and see if did that help, Dr. Lucas? Good question.
Yeah, it does. I just think, when we create that story, we just need to make sure that whatever recording is in that patient's scope.
Absolutely. Thank you. No, definitely great point. All right, moving us right along. See if there are any other questions, comments.
I think Jim, would you like to go ahead?
Oh, sure thing, Shital. I appreciate that. No, I just wanted to follow up on Emma's comments and I make sure that my comment was clear about Helios. So at the end of the day, a Helios formatted fire resource can work with a gravity formatted fire resource because they're still both fire objects. So if that was part of your question as well, that is included or considered as part of the technical interoperability.
Thanks so much, Jim. And hopefully, yeah, Dr. Lucas and others, that helped.
Yeah, thank you.
Yes, thank you. I did just put in the chat the link to the HL7 Confluence for Helios, which is a fire accelerator project for public health. Thank you, Jim, for elevating the great work going on. And we have, we are aligned working with CDC and who are one of the spearheading that Helios initiative with many other wonderful community members. So some of you overlap, which is great. So we are able to share among each other. So I know we're a little early. If there are no other questions, we'd love to give you a little bit of your time back. As mentioned, if you haven't done so, we really encourage you to join as a committee member or other interested party. As mentioned, committee members will be able to vote. If you already signed up and are not sure about your status, or you want to switch from other interested party to committee member, you're able to do so. Just please send us an email. We'll be happy to take care of that from our end. You don't have to register twice. We're able to make that switch on our end. For any work group information or questions, you can contact us, myself, Gabriella, Sarah Behol, who's supporting us behind the scenes today, as well as Kyla Davis, who is our point of contact at CDC. Without further ado, we'll give you back your time. We really want to thank you for participating in this national consensus building process. We are so close. You'll be receiving an email once the package via Word document is up and ready for your review. And we look forward to hearing from you by July 18th. Thank you all so much. Appreciate the input today.
Excellent work as always. Thanks.
Thank you. Bye.